So these are the disorder you can study. These are the disorder protein involved in bilirubin catabolism. Okay, you can remember the protein name. I am actually reviewing here protein name. So bilirubin catabolism, first you already know two proteins. First two proteins in bilirubin catabolism are enzymes. First is heme oxygenase. HOBR, you can remember HOBR is the first two. HO means heme oxygenase, BR means biliverdin reductase, HOBR. So HOBR two proteins are there inside macrophage, one in endoplasmic reticulum and other in cytosol. Next protein is, you can see albumin that will bind it. Albumin that will bind it. So I am not talking about these three protein here. I am directly coming to this because these are, we have already done the function. Here we are talking about the function. Ligandin Y protein. This ligandin or Y protein. Ligandin Y protein is actually, this will bind actually bilirubin, retain bilirubin. So we have, I have already explained a little bit this. So it will retain bilirubin in hepatocyte, unconjugated bilirubin in hepatocyte. So this protein UGT. So UGT is different type of 1A1. You can remember 1 is first number, A is also first number, again 1. 1A1. This is a, there are types of UGTs. This is a type of UGT that is actually required for conjugation of this conjugation of glucuronic acid to bilirubin. So UGT1A1 for conjugation. And there is a different protein, as I have told you. Did you remember the protein name called MDR1? That is present in enterocyte. This protein is present in enterocyte, and it is actually required for actually excretion of B12, vitamin B12. Do you remember this protein?
Yes, sir.
Last class I told you, I told you in last class. So this two protein, this protein is M multi-drug resistant MDR. This is called MDR, and this is also multi-drug receptor protein 2. This is a different group. These all are ABC, ATP binding. I'm writing you ABC means ATP binding cassette protein. The function of all this protein is to throw outside, and this is fall into the group CB, ATP binding cassette group B, and this fall into group. This all protein has function is throwing something outside the cell. Simple, throwing something outside the cell. The function of ATP binding ABC is throwing something outside the cell. I will give you few examples you have already studied. Now you can see MRP. I'm teaching you actually a different type of protein also. So remember that MRP2. Actually, it will throw what? It will throw this conjugated bilirubin outside the hepatocyte. Now this is fall into group of, this is also ATP binding cassette protein, but this fall into the group of C. Now I will tell you one more protein you have already studied. Do you know this cholesterol transport protein? Cholesterol transport protein A, B, C, A, 1 or A. Do you remember deficiency of this will cause a disorder called Tangier disease? We have done in lipoprotein metabolism. This is also ATP. This actually ABC, ATP binding cassette, throws cholesterol outside the cell. So remember this ABCA1. Have you remembered CFTR? Tell me.
Yes, sir.
Yes, CFTR is also ATP binding cassette protein. It throws chloride from the outside the cell, and that is how with chloride, though it will actually, the water will be rich in chloride, mucus will be rich in chloride, and with chloride water will stay with chloride. If chloride is not there, water will not stay with it. So this CFTR is also this ATP binding cassette. This is also fall into C group, actually C7. This is C7. So remember this 4 ATP binding cassette, all have the same function, throwing molecule outside the cell. Make this a note. 4 types of, we have studied 4 types of protein. Just remember, one for vitamin B12. This is for B12. It is also very, this is for cholesterol. One is for cholesterol. This is for your bilirubin, conjugated bilirubin. And this is for chloride. And you know, this is also very important. This is very, very important. So you can, if you remember, this is also important. This ABC1, A1. All are important. Make a note and remember, these all are ATP binding cassette protein. All have the same function, throwing molecule outside the cell. Excretion outside the cell. Maybe vitamin B12 can be the molecule, chloride can be the molecule, bilirubin, conjugated bilirubin can be the molecule, or cholesterol can be the molecule. So I have explained this by correlating with others. Now you can see here, last but not the least, this is also. So you can see the protein I have related, I have also written the disorders. So UGT1A1 deficiency will cause this uridyl, the enzyme deficiency that causes conjugation deficiency of this enzyme that causes conjugation will lead to this disorder, 2 group of disorder, Gilbert syndrome and CNS is Crigler-Najjar syndrome. Okay, and this is actually level of deficiency. If completely deficient, it will cause Crigler-Najjar syndrome 2, 1. And if there is residual activity, little bit of activity is there, very less activity, that is not sufficient. So 1%, maybe 1% of activity is there, it is called Crigler-Najjar syndrome 2. If there is 10% of activity, it is called Gilbert. So this is a benign condition, but these 2 condition has manifestation. The problem manifests in this Crigler-Najjar syndrome 2, 1 and 2. One is very severe, other is milder than this. So this is 2 syndrome, Crigler-Najjar syndrome, Gilbert. Easily remember, G and C are remembered same, written same way. So you can remember Gilbert and Crigler-Najjar syndrome. You can imaginative memory, you can put the pictorial memory of this G and C. So 2 types of disorder happens because of this enzyme deficiency. Now MRP deficiency will cause, this is also a very benign type of condition, Dubin-Johnson syndrome. Okay, this excretory protein, if the hepatocyte is not able to excrete outside the hepatocyte, it will regurgitate. The bilirubin will regurgitate in blood, conjugated, and this will also appear in urine. So this will cause urine very dark blue, actually very dark yellow. So this will cause urine dark yellow. This happens in congenital disorder, Dubin-Johnson syndrome. And if this protein is absent, I will tell you where this protein is required. This protein. So this is hepatocyte. This is hepatocyte. In hepatocyte, here biliary canaliculi. Here, what is present? Here is presence of MRP1, MRP2, and you can easily remember maximum retail price. MRP means maximum retail price. That is how you can easily remember. So here is the presence of O. You can also remember ATP. So O, ATP, ATP 1B1. So this is present here. Now what will happen? Not all conjugated bilirubin go out of this. Some bilirubin regurgitate back. Okay. So what does this channel do? The regurgitated bilirubin, conjugated bilirubin will be taken back by this. Okay. So that this blood will not have this conjugated bilirubin. This makes sure that all conjugated bilirubin will appear in the bilirubin canaliculi. So regurgitated bilirubin will be normally regurgitated bilirubin taken up again by this O ATP, organic anion. O means organic anion transporter protein. So you know this bilirubin, conjugated bilirubin is also an organic anion. Isn't it organic anion? Tell me, answer please.
Yes, sir.
So this transport regurgitated. So these are the protein you can see. Okay, these are the protein. Now, if there is defect in this protein, OATP, this will cause rotor syndrome. And then this is also syndrome of conjugate. This both are syndrome of conjugated bilirubin. One does not allow, one if it is damaged, so regurgitate, and regurgitated bilirubin will not come back. So which one will be more severe between two from this concept?
Sorry, what do we Rotor syndrome?
Yes, not Rotor syndrome. Rotor syndrome will be less severe, okay? Because it is viable, only few of them regurgitated back, and it will come. And that it has less bilirubin, less conjugated bilirubin. It has very high amount of conjugated bilirubin because the pathway of excretion is completely blocked here, and that is why Dubin-Johansen will have more conjugated bilirubin. Actually, in both cases, the patient will have normal life. Actually, generally, patient will have normal life, but this can sometimes, I will tell you what happens in Dubin-Johansen syndrome. One problem happens in Dubin-Johansen syndrome because of that color of liver changes. The color of liver here remains same. So that is the basic difference here. But the normal life, the both will actually live appreciably normal life. There will not be that big problem. So you can correlate everything with this drug transport. Bilirubin metabolism you can apply to the drug transport when you study pharmacology. So remember this bilirubin catabolism. And if you remember bilirubin catabolism, you will easily remember the catabolism of drug. The same way you can see the bilirubin catabolism, also this drug catabolism, it actually drug transport happens by binding with the albumin protein. Okay, albumin protein. And then in liver, it will go through two processes. First is hydroxylation, OH addition, and third is glucuronide conjugation. So drug also go through the same process. And here you will see the drug have same organic anion transporter. Here it also, because many drugs are organic anion. So there will be organic anion transporter. Some drugs are cation also. So there can be cationic transporter. OCT can be there. So it is not written here. So there can be neutral transporter. There can be cationic transporter. So this drug transporter can be there. There will be many. You can see this is OATP A1B1, the same molecule that transport conjugated bilirubin, also transport drugs also. Other OATP will transport drug into the liver's hepatocytes. So you can see many drug after conjugated, it will be eliminated also in bile. So different types of MRP and these other proteins. You don't need to remember this all protein. You can see the same type of protein you have seen in this with vitamin B12 excretion. This is also called P glycoprotein, MRP. The same type of protein also present in liver that will excrete drugs. So this type of protein, the type of protein we have studied, same type of protein are involved in drug absorption, in uptake and transportation into bile. So remember, if you remember that, so you can correlate that with drug. You can read yourself this. So you can see drug transport protein. These are the drug transport protein, OATP, ATP, OATP, OATP, OATP. You can see these are anionic drug transporter. And you can see OCT, means cationic drug transporter are there. So this transporter will transport this drug. And then after transporting this drug, the drug will be thrown out of the hepatocyte into bile. Okay, by the different types of protein, the similar protein to all are ABC, ATP binding cassette protein will throw out of this P glycoprotein is also a type of ATP binding cassette protein, ABC protein. So this is, remember, whatever cell is thrown, it is ABC protein, and ABC means, from the name, it will require ATP. It will utilize ATP to actually pump those all toxic material out of the cell, or also sometimes usual material from this out of the cell. For example, chloride is useful material. For example, cholesterol actually is thrown out of the cell. It is sometimes, if it is accumulated, it becomes toxic. So that is, you can take it as toxic also, as sometimes it is also good thing. So you can answer this question: what are the names of bilirubin byproduct that are produced during heme catabolism, heme metabolism? Names of byproduct, bilirubin byproducts. Please tell me. So heme.
Urobilinogen.
Yes.
Urobilinogen.
Okay, that is actually biliverdin. Actually, when bilirubin it converts into bilirubin. So when it converts into bilirubin, then what is the actually this is the Heme catabolism, and ultimately bili. Okay, one is true. Okay, stercobilin, that's good. Stercobilin can be. It is not a byproduct. It is a product from Heme catabolism. Ultimate product stercobilin, urobilin. So byproduct, byproduct I have told you, carbon monoxide. It's the byproduct. Can you see byproduct carbon monoxide? Can you see the byproduct Heme, ferrous iron? So in order to focus this, I told you, I'm actually carbon monoxide in very low quantity. It behaves like nitric oxide. Remember that this is nitric oxide, and it is a vasodilator. So it is carbon monoxide also perform like vasodilator. Very slight amount of carbon dioxide released from Heme catabolism will function as vasodilator in spleen and other places. So this is the significance of this byproduct. Now, 5 important proteins in bilirubin metabolism with its function. Will you tell me the function? 5 proteins. First is heme oxygenase. You know the function. Second is biliverdin reductase. You know the function. Third is what is the protein? Ligandin. You know the function. Fourth is what protein? UGT. 1A1. What is the function? Fifth is which protein? After UGT, MRP2, you know the function, and sixth protein, you know, OATP. 1 is B2. What is this? So we go and see. What is this? OATP 1B1. Okay, these are the proteins. So which is more lipophilic, conjugated or unconjugated bilirubin?
Conjugated, sir.
Lipophilic?
Unconjugated.
Yes. Unconjugated bilirubin is more lipophilic. Neutralizing this. Okay, so this is conjugated bilirubin. Unconjugated bilirubin is lipophilic. Lipophilic means insoluble. So where are most of the macrophages located that are responsible for breaking down senescent cell, RBCs? Spleen. Okay. What byproduct gives urine its distinct color? Urobilin. What? Stercobilin. So these are the. So let's talk a little bit about this liver function. If we talk about little liver function test here a little bit, we will have time to discuss questions and cases. That is why I'm good. So we can utilize this 10 minutes, then we will able to do our questions nicely in next class. In maybe we don't have today, but after today last class we will able to discuss question and cases. So stages of jaundice you can see. So these are the stages of jaundice in neonates. Because we focus more on congenital things, that is why we are talking like that. So you can see this normal bilirubin is about 1, remember, less than 1, and hyperbilirubinemia is more than 1, about 1.2. So more than 1.2 is 1 and 2. So you can remember 1, 2. So more than 1.2 is hyperbilirubinemia. Less than 1.2 is normal. Now, what is jaundice? Jaundice is the blue, actually yellowish sclera, yellowish pigmentation that happens. It is because of increase in bilirubin. When it is bilirubin, high bilirubin is visible outside in mucous membrane, and then in your sclera, this is called jaundice. You must be knowing from ICM. So this is called jaundice. Jaundice is seen in upper bulbar sclera. You know it. So if the concentration rises above 20, so you can remember 2, 1, 2, 2, and 2. You can see only 1 and 2 are repeating here. 0.2, 1, 2, 1, 2, and here 2. So more than 2 mg is jaundice. More than 20 will cause kernicterus. Kernicterus happens in Crigler-Najjar syndrome. In baby, in Crigler-Najjar syndrome, baby can have kernicterus. What is kernicterus? When unconjugated, this is more than 20 unconjugated bilirubin. Unconjugated bilirubin, because it is lipid soluble. So if it is very high, it will cross blood-brain barrier. Blood-brain barrier, and it will damage brain. Okay, it will damage brain, especially basal ganglia. Okay, you know, basal ganglia if damaged, what will happen? The basal ganglia is related to motor function. If it is damaged, there will be different type of motor function. Uncontrolled motor function can be seen in such patients, in such baby, infants. Okay, so these are the stages of hyperbilirubinemia, bilirubin in infant. You can see this yellowish pigmentation. And then here you can see, this is the picture whole snapshot from your first aid. And this is from pathology. If you study this about this, you are studying pathology, in fact. Rather than biochemistry, you are applying thing, studying pathology. You can see this sclera. So this is jaundice. Jaundice can be because of this region. So they have given 3 reasons. I will tell you the reasons of jaundice. No, don't worry about it. Hemolysis obstruction, tumor, liver. This we will talk about this all. So you can see the conjugated, they have written conjugated hyperbilirubinemia, unconjugated hyperbilirubinemia. What causes conjugated hyperbilirubinemia? What causes unconjugated hyperbilirubinemia? In what condition there will be both conjugated and hyperconjugated? We will talk, we have a good table, we will talk about that. Now physiological jaundice is also very important. You can see the physiological jaundice is normally the actually bilirubin will have degradation will happen in baby after birth, after 1 week. So it is because of immature UDP glucuronide. The glucuronide transferase is low. Activity of this UDP glucuronide transferase is low. This is the reason this neonatal jaundice will happen, because the bilirubin will not be conjugated faster because of lack of this UGT1A1 enzyme in baby. So bilirubin will not be conjugated faster, but the load of bilirubin is very high, because you know baby hemoglobin is actually fetal hemoglobin. Fetal hemoglobin is converting into adult. So what will happen? This fetal hemoglobin will be degraded, and therefore the bilirubin load will be high in newborn infant, and this is the activity is low. Bilirubin load is high, activity is low. What will happen? Bilirubin concentration will be high in blood, and this will cause, this is the cause of normal type of jaundice. Every baby goes, but in some baby you have to take care. In some baby, if bilirubin becomes very high, the baby can have problem like seizure because of this kernicterus. So in that condition, you have to treat this patient with phototherapy. You can see this is non-UV light. Again, this is the light of 450 nanometer, 450 nanometer light. So this is blue light. I told you 450, cytochrome 450. Why? Because you can understand this also. Light of 450 is blue light. So you can use blue light to treat this patient. This is the very important 2 condition. Now bilirubi atresia, you can read yourself. Bilirubi atresia, it is completely purely part of your pathology. It is most common cause of atresia, means duct will be blocked. So bile duct will be blocked, bile will be accumulated, and bile is also toxic. Okay, cholestasis, bile, if it is very high in your liver, bile function like a soap. You know what is soap? Soap is salt of organic acid. So this is bile is also salt of organic acid. So it will function as soap. Soap means it will damage your membrane, hepatocyte membrane, and that is why hepatic damage happens because of biliary atresia, and this liver transplant will have to be done. So these are the part of your this. You can see this disorder we have already done. Gilbert syndrome, I told you, Crigler-Najjar syndrome, type 1. And type 1 is very important, more important than type 2, because completely absent. UDP is completely absent here. Absent. Here mild activity is there. Okay, but mild activity. The same you can see in baby. So this condition you can see, though there is mild activity, but mild activity will work fine in normal condition unless patient is undergone stress like fasting illness. If patient undergoes this stress illness fasting, then only the patient will have symptom mild jaundice. So this is a very important condition in Gilbert syndrome. Otherwise patient will be fine. I have two friends which have this Gilbert syndrome. Person is very fine. Only the person have this high bilirubin in acid when the patient goes through stress condition, exam, when he goes through some other stressful condition, don't get good sleep, when he undergoes fasting. These are the conditions where there will be high bilirubin. So this is relatively benign condition and rarely, okay, relatively common condition, because I have also seen two of my friends have Gilbert syndrome. That is why. And Crigler-Najjar syndrome is rare. It is rare and it is very devastating. It is very devastating because you can see Kernicterus is the very big problem of this Crigler-Najjar syndrome 1, and it will cause high bilirubin. What is the problem? How you do? You exchange the plasmapheresis. You do phototherapy repeatedly in such patients, and liver transplant can be done. Has to be done in such patients. Is curative. Liver transplant is only curative in such patients. Type 2 is less severe. Type 1, see here, type 1 is given because type 1 is the deadly. 1 is deadly. Dubin-Johansen syndrome, you can see there is one thing, notable thing, gross black liver due to impaired excretion. The same way this epinephrine metabolite is also excreted. Okay, this epinephrine metabolite is not excreted. Because of that, what will happen? There will be accumulation of there. VMA is the bilirubin excreted. Valine mandelic acids are the actually accumulated inside the liver. And because of its accumulation, what will happen? This liver will turn dark. But this is not the case because MRP is intact in such condition, Rotor syndrome, MRP. So this is not the case here. This will be excreted nicely here. So liver will be regular. But the conjugated bilirubin due to defective, and you know, sir, this is benign condition. You can see this is benign. This is also benign. But one problem you can see in Dubin-Johansen syndrome, liver is dark. Here, liver is regular. So this is the two difference between Dubin-Johansen and Rotor syndrome when you see physically. So is time over?
Yes, sir.
Okay. So we will talk about this. We'll talk about this. You can go through this easily. So you can see this. I have classified into this three category. One is congenital, other is acquired, and third is neonatal jaundice. Okay, this is normal condition, sometimes require treatment. Here, they have two types of this disorder. Red, the marked in red are isolated unconjugated hyperbilirubinemia. You can see unconjugated hyperbilirubinemia has been marked in red. This is conjugated bilirubinemia, and this black is both conjugated. Here only you can see both. Hepatic jaundice, the infection case, other cases you will see both. In pre-hepatic jaundice hemolytic you will see unconjugated, post-hepatic you will see conjugated, and here in this two condition only you will see enzyme associated with enzyme. And Crigler-Najjar, this is Gilbert, these have normal liver enzymes. So from this we will again start. So I actually already told you most of the thing about the hepatocyte. We will talk about liver function test, and then we will go on solving questions. And I want you to revise this chapter nicely so that we will be doing question nicely. So so that you will participate in our discussion. We will do question, we will do cases. in next class. Most of the class will be dedicated to cases. We have 7 cases to discuss. So I want you to revise this. Okay. So will you revise?
Yes, sir.
Okay, I will take the attendance. Okay. So I will see the attendance which Sonia. So how many? 1, 2.